All right, so I think we'll get started here. Thanks so much to everybody else for coming out tonight. We're very excited to have you. For those of you who don't recognize my smiling face yet, my name's David. I'm an officer in the training department here at Div 176 in Victoria, BC. We're extremely lucky tonight to have Dr. Nav Chima presenting for us. He's our divisional medical officer here at Div 176, and I'll let him introduce himself in just a minute here. Just a couple housekeeping things while we get started. We've turned off everybody's microphones and video, and we're asking everybody to keep it that way for the duration of the presentation. It just makes it much easier for everybody else to see and hear what Dr. Chima is talking about instead of getting distracted by somebody's dog getting too close to the microphone. As we're going through, if you have questions, please put them into the chat box. We've got some really nice breaks built into the presentation here, and we'll get those questions answered as we go. But while we're doing that, please leave the questions for a presenter to answer. He's very, very knowledgeable about what he talks about. We've just had some issues with some less than accurate answers being put in the chat box from other folks before. These are being recorded. They're posted on our YouTube channel, and you can see all of the ones we've done up to now. So almost 5 or 6 months worth now, at least, all posted up on our YouTube channel, and we'll bring the link up for that at the end of the presentation here. With that all out of the way, I'll let Dr. Chima take it away here.
Thanks, Dave. Always a pleasure to be back. Dave, just confirm you can still see my screen. I had to jump out for a second there.
I can see you, no problem.
Okay, perfect. Hi, everyone. My name is Nav. I'm a divisional medical officer at 176 in Victoria, my hometown. Currently, I'm in Toronto. I'm doing a fellowship in anesthesia at Sunnybrook Hospital, doing some perioperative ultrasound training as well as some extra trauma training. Really nice to be here in Toronto. The first time living away from home. I guess I'm from Vancouver. I'm living in Vancouver otherwise, but yeah. So we're going to be talking about heart structure, function, and disease. We're changing topics a little bit here in the fall. We're going to be focusing a little bit more on some basic physiology, pharmacology, some anatomy thrown in. And then the idea is that these talks will be a stepping point for people to branch out into other discussions, or if you want someone to go deeper into something later on, then we can do that from here. So today's talk is going to be kind of like a big overview of everything you ever wanted to know about the heart and heart disease. Certainly a big topic, but we'll kind of go over it from a looking down perspective and go over the different parts of the heart and focus a little bit on some diseases that can occur and some treatments that we do for those diseases. So this is very overview. We're going to be building a good layer and building on top of that. So what are we actually going to be talking about today? So we're going to focus on heart anatomy and some basic physiology of the heart. And then we're going to go into some of the structures of the heart and focus on the valves. We're going to talk about the conduction, that's the electrical system of the heart. We're going to talk quite a bit about coronary blood flow, which is a bit of an interest of mine. And then we're going to talk about heart failure. So this kind of is kind of like a step back from Dave's talk a couple weeks ago on chest pain. We're focusing just on the heart here and going through a bunch of different aspects of that. I am going to break after each section for questions. Dave will be keeping an eye on the chat, and I'll answer them as I can from the chat at those breaks. Okay, so let's get started. So let's start with some basic heart anatomy and physiology. So good review here. Let's just go right down to basics. So the heart is a muscular organ in the chest, comprised of 4 chambers. There's 2 per side. You have 2 atria and 2 ventricles. And as I said, you have a right atrium, right ventricle, and then left atrium, left ventricle. The atria receive blood and then pump it to the ventricles, and then the ventricles will pump blood out of the heart into their respective types of circulation. There's 2 what are called great vessels that come out of the heart, and these are where the blood exits as it goes to different parts of the body. So from the right side of the heart, the blood exits the right ventricle and goes through the main pulmonary artery before it branches into the right and left pulmonary artery, and blood goes to the lungs. Now this is deoxygenated blood that doesn't have very much oxygen in it, and it's going to the lungs to be oxygenated. The aorta is the main blood vessel leaving the left side of the heart, and it carries blood to the rest of the body, and it comes from the left ventricle, and it's carrying oxygenated blood to the rest of the body where it has to go. So the brain, kidneys, gut, liver, even the heart all gets oxygenated blood from that. There's also two venous returns to the heart. The vena cava, which actually doesn't exist. You have the superior or the inferior vena cava, and this receives blood from the upper part of the body or the lower part of the body, and this flows into the right atrium before going to the right ventricle and then pumped through the pulmonary artery to the lungs. And then from the lungs, the blood returns via the pulmonary veins to the left atrium. Pulmonary veins are usually 4, but they can be anywhere between 3 and 5. Nice basic start there. So if we're looking at the actual flow of blood through the body, blood comes from the body through the superior and inferior vena cava to the right atrium. From the right atrium, it goes through the valve into the right ventricle. Right ventricle gets pumped out of the pulmonary artery into the lungs. From the lungs, returns to the left atrium, now oxygenated blood, via the pulmonary veins through the heart valve and into the left ventricle. And then from the left ventricle gets pumped out through another valve into the aorta where it goes to the rest of the body. And the diagram on the right here, to make sure I can turn on my annotation mouse, perfect. So the diagram on the right here shows the two types of circulation that are in the body. I know there's various vascular beds that are there, but I want you to just focus on the color of blood. So right side receives deoxygenated blood and pumps it to the lungs, to the pulmonary circulation to be oxygenated, then returns to the left side of the heart and gets pumped all to the different parts of the body. So abdomen, lower extremities, upper extremities, and all that gets oxygenated blood to for the body because it needs it, and then returns back to the right side of the heart via the venous system. Okay, nice and simple to start off with. Now, what I do want to do is just go over a couple basic physiology terms that kind of define all the different diseases we're going to be looking at. And whenever you have a cardiac disease, you can actually describe it in all of these terms and the disturbance or the imbalance that occurs between these. So the rate is just whatever the heart's beating at. It's your heart rate, it's your pulse, it's what you're feeling as it's going. But note that you can actually talk about rate independently of the different structures. So you can talk about the ventricular rate, which is the rate that the ventricles are beating at, and the atrial rate, which is the rate that the atria are beating at. And most of the time, these are the same, but certain diseases can change that, where you might have the atria beating faster than the ventricles. The rhythm refers to the actual pattern of the beat. And normally we have our typical lub-dub pattern where the atria contract followed by the ventricles contracting, and that's in a 1-to-1 ratio, as I said before. But a rhythm disturbance can cause dyssynchrony in that, where the atria might beat faster than the ventricles, or they may just not be beating at all, and they might be quivering. That's a term called fibrillation. And that rhythm disturbance can have various implications in the body. And then we have 3 different states of filling and ejection that we can talk about. We talk about preload, afterload, and contractility. Preload is the amount of blood returning or entering the heart. And again, like with the rate where we can talk about different structures, we can talk about preload as in the amount of blood returning to various parts of the heart. So generally when people talk about preload, we're talking about the left side of the heart, because that's what a lot of people care about, because that's the side that pumps blood to the rest of the body. But you can talk about preload to the right side of the heart. You can talk about preload to specifically a ventricle or a atrium. But for the most part, when you talk about preload, it's how much blood is actually entering that structure before it's about to be ejected out. Afterload is the force against which the heart has to pump in order to eject the blood. And again, normally when people talk about afterload, they're talking about the left side of the heart, specifically the left ventricle. But again, you can talk about the afterload of any structure in the heart. But the thing you want to remember when talking about afterload is just remember it's the force or the resistance that that structure is having to work against in order to eject blood. So the left ventricle, when it's pumping blood out of the left ventricle into the aorta, it's working against all the pressure it sees across the body, because that's what's going to take to help open the valve. Whereas the left atrium is only working against the pressure that's in the left ventricle to pump blood and keep blood going the right way. Contractility is the last term, and that's how hard is the heart pumping. So if you increase contractility, then the heart's going to pump harder and squeeze harder to force blood out. And if you decrease contractility, the heart's going to pump less and have less force to eject blood. There's 2 phases in the cardiac cycle that we talk about, systole and diastole. Generally, when people talk about these terms, they're talking about ventricular systole and diastole, but you can also talk about atrial systole and diastole. Systole refers to contraction and diastole refers to relaxation. And this is where we get our systolic and diastolic blood pressure from. Systolic blood pressure is the maximum blood pressure when the heart beats, and diastolic blood pressure is the maximum blood pressure when the heart's not beating. Okay? So before we go on to heart valves, any questions there? Let's have a look at the chat. I don't see any questions in chat. I'll just wait in case anyone's typing anything. All right, so we'll just keep going and I can always circle back to something if needed. So as I said before, we have 4 valves in the heart that separate the 4 different chambers, and they function to prevent blood flow. We want blood to just circle in one direction all the time. Backflow of blood would be bad because not only could you have mixing of blood that could be deoxygenated and oxygenated, but you could also have congestion where one ventricle or atrium becomes overloaded compared to everything else. Now, the valves are in sets because of how they are derived embryonically. And the valves that separate the atria for the ventricles, they are the mitral and the tricuspid valve. The mitral sits on the left side and separates the left atrium from the left ventricle. And the tricuspid sits on the right side and separates the right atrium from the right ventricle. And they're kind of like these big sails that are tethered by cords. The cords are called chordae tendineae. And those cords are attached to these small muscles on the inside of the ventricle. And these small muscles will actually contract when the valve closes and prevents it from what's called prolapsing, becoming leaky and flailing. And in certain disease states, these muscles can fail, and that might be a cause of a leaky valve, which we'll get into shortly. The valves that separate the aorta from the valves that separate the great vessels from the rest of the heart are the aortic and pulmonic valves, aortic to the rest of the body and pulmonic to lungs. And they sit right at the end of the left ventricle and right ventricle and at the entry point to the great vessels. And just like the other valves, they prevent backflow of blood. These are differently shaped. These are cup-shaped valves. And they close and open to allow blood to flow through. The aortic valve also has a secondary purpose. It actually has a specific shape that allows blood to flow into the coronary arteries and provide perfusion to the rest of the heart muscle. Now, people may wonder, well, what prevents blood flow from going back into the vena cava and from blood flow from going back into the pulmonary veins? Well, nothing really. It's just passive flow that keeps blood going, and the fact that the atria are very low pressure chambers. And whenever they are experiencing high pressure from the ventricles, the mitral and tricuspid valves are closed. So in a normal state, there should be no backflow into the vena cava or the pulmonary veins. So there's actually no need for any valves in those areas. So when we actually look at the valves, we're going to take the heart and we're going to slice it right through the middle, right through this line. Annotation is here. Oh, look at all these options. Okay, we're going to slice this right like this kind of. And then this is looking at the top of the heart. Anterior is the front. So this is the front of the heart. This is the back of the heart. And then we have the right side and the left side over here. Whoop, let's go back here. There we go. And so this is what the valves actually look like when you cut the heart in half and you're actually looking at them. You can see they're actually very close together, but they're still separated by all the chambers and everything. Let's focus on these 2 valves here. So the tricuspid valve and the mitral valve. The mitral valve is 2 leaflets, an anterior and a posterior leaflet, where the tricuspid valve has 3 leaflets, but they also close and act the same way. Mitral valve is called a mitral because it resembles a bishop's mitre. Fun trivia fact for you there. Yeah, anterior and posterior leaflet, and tricuspid valve, 3 leaflets there. The aortic and pulmonic valve look very similar. Aortic is a little bit bigger, but still 3 kind of cup-like segments that can occur. Let's erase all that. And that one, perfect. Okay, so the valves can become diseased, and the most common types of disease can occur, usually stenotic or regurgitant lesions. If you have a tight valve, a valve that prevents blood from flowing through properly, that's called a stenosis. Whereas if you have a leaky valve, that's a valve that causes a backward flow of blood. That's called regurgitation. And you just combine that with the name of the valve, and you basically have your disease right there. So if you have aortic stenosis, that means your aortic valve is quite tight. And what can occur is that the heart has difficulty pumping blood to the rest of the body. And it ends up becoming so small and so tight that even though the heart's trying to contract as much as possible, it's increasing its contractility, it's trying to force blood out, it can't meet the demands of the body. Let's say if someone was exercising, and this can lead to someone fainting because there's not enough blood going out and reaching the rest of the body, like the brain. You can also have aortic regurgitation, but I'm focusing on aortic stenosis as an example. Another disease that you can have is mitral regurgitation, where the mitral valve becomes leaky. And this now allows a backflow of blood into the lungs. And that's not where any extra blood should be. And what happens is that because the lungs are now seeing this higher force than before and receiving more volume than they're used to, because remember, even though they're having all this backflow of blood from the lungs from their left ventricle, they're still receiving the same amount of blood from the right ventricle. So now the lungs get overloaded with fluid and become wet. And that's the term called pulmonary edema. And that's where we talk about when you say like you hear crackles in somebody's lungs with heart failure. And it can even backflow even more and backflow all the way to the right side of the heart and down into the vena cava. And that's when somebody might develop swollen ankles, because now that blood is flown all the way back to that way. And that's one of the presenting symptoms of mitral regurgitation or backflow of blood through the mitral valve. Just like with the aortic valve, you can also have mitral stenosis as well, where there's a tight inflow between the left atrium and the left ventricle, and that has various disease implications as well. I didn't mention the tricuspid and pulmonic valves here, but they can also become stenotic or regurgitant. Generally, generally pulmonic and tricuspid stenosis are congenital diseases, as in usually you're born with them and then you have to have it fixed in childhood or infancy. And tricuspid regurg is common, but usually that's a secondary effect of another disease process like previous heart attack or dilation of the ventricle, or developing tricuspid regurg because you have mitral regurg and so much blood backing up through the body. Now, when this happens, there's various things that we can do to treat this. Most commonly, we start off with medical management, and that's going to be specific to the actual disease type. So if it's mitral regurgitation and you're in heart failure, then we're going to give you medications to treat your heart failure. So diuretics so you pee out the extra fluid that you have. But usually these diseases have to be fixed by a surgical technique, and this can be fixed either by a minimally invasive technique or via open heart surgery. There's two really cool technologies that are coming out actually I say coming out, they're already out. We're doing them as we speak. So if you have a dysfunctional aortic valve, usually this is done if the aortic valve is too tight, but you can do it if the valve is also leaky, is a intervention called TAVI, transaortic valve intervention. And what they do is that they have a catheter with a deployable valve on it that goes all the way up in the aorta, goes backwards up the aorta and goes into the defective aortic valve. And then they'll deploy the valve, they'll pop it open with a balloon and implant a new valve in that spot. And it's a foldable valve, so they can bring it up through the catheter and then pop it open like a balloon. And now the person's got a whole new valve there that replaces, because they basically crushed the old valve to the side, the old one. With a defective mitral valve, this is more for if you have a mitral regurgitant lesion. What they can do is they can take a catheter, so a little plastic tube, and they can go up the vena cava, and then they can puncture through from the left side to the right side of the heart, and then bend the arm with a little clip, and it's called a mitra clip. And a regurgitant valve that's leaky can be caused because the leaflets, those giant sails, are kind of flapping in the wind, and they're a lot looser than they should be. And so what they can do is they can take this little clip and they can clip the two sides together to kind of tighten it up a little bit and prevent a lot of that leakiness from occurring. These are two kind of really cool technologies, and they're done at Sunnybrook, and it's kind of fun to see. They're done all over the country. I just mentioned that now. And then, of course, if you can't do those, then you can go on and do open heart surgery, where you can either do a primary repair. So the surgeon may throw some stitches in to fix a leaky valve or make some cuts in an otherwise stenotic valve, or more often than not, just replace the valve at the time. All right, any questions about that? I think I saw one pop up here. Let's have a look. Would TAVI be prone to clots? Yes, it can be prone to clots. So Mike H asks about whether that transaortic valve implementation, so this one up here, let me make sure I'm still on annotation. There we go. This one up here could be prone to clots. And yeah, it can be. So just like any valve replacement, patients usually go on certain types of blood thinners afterwards. But depending on the type of valve that's implemented, the length of time you have to be on blood thinners is a lot shorter. So when you go for open heart surgery, you still, for a valve replacement, you still might need some blood thinners afterwards, but usually the time is shorter. And with some of these, you're usually on blood thinners for some period of time afterwards. See another question here. Oh, cool. Yeah, happy to answer. Okay. Okay, so from valves, we're going to move on and talk about the conduction system. Getting a little bit more complex here, but I think this will be good as an overview. So the heart has kind of two main cell types. It has the muscular system, which is the actual pump, and that's what's squeezing to actually eject the blood all the time. But then it has the conduction system, and the conduction system is the electrical system of the heart. It's literally the wiring of the heart. And it has two functions. It both initiates and conducts the electrical systems, signals in the heart, and helps coordinate the heart to beat in a synchronous fashion. If we didn't have this electrical system here, then all the different parts would be contracting not really well each other, and the whole heart would be fibrillating. We'd never have forward flow in the heart. And so the fact that we actually have this conduction system actually allows the heart to beat in synchronicity and allows the atria to beat, dump blood into the ventricles, and then the ventricles to beat together and pump blood to the rest of the heart. Now, one thing to note is that you can still conduct electrical systems through the muscle. In fact, that's how you recruit the muscle to contract together. But what you need is you need the signal to arrive in all the different areas of the heart at the right times. And that's what the conduction system is there for. And we can detect that electrical signal using electrocardiogram or EKG, ECG, and you can make different diagnoses on the kind of shape that you have there. So the electrical system has four main components: the sinoatrial node, the AV node, the bundle of His, and the Purkinje fibers. The sinoatrial node, or SA node, that's called the pacemaker of the heart. It sets the rate that the heart's normally going at. It's one of the primary drivers of your heart rate. And depending on your stress state or what else is going on in your body, this can be increased or decreased depending on the needs of the body at the time. And it's made of very special cells that not only conduct electrical signals, but they're just constantly going off by themselves, and they have a reset loop on them that actually dictates how often they're firing. From the sinoatrial node, we have various pathways that not only carry the signal to the AV node, but also carry the signal to contract to the left side of the heart. And that's actually good because you want both atria contracting at the same time, so you don't have dysynchrony there. So when the sinoatrial node fires, it sends signals to the right atrium, to the left atrium, and signals to the AV node. Now, when that signal arrives at the AV node, there's a little pause, because we want to have a little pause so that the atria can contract and empty their blood fully into the ventricular system. And after that, the AV node fires. And when the AV node fires, it sends a signal down a structure called the bundle of His, which divides into the left and right bundle, because we have to get the signal to the left and right ventricles. And from there, each bundle kind of spreads out into these things called Purkinje fibers. And those fibers carry the signal all around the ventricles, because the ventricles are big, thick muscle. And so you have to get that signal all the way around, and that's going to help coordinate the ventricles to contract together. And that's what happens over and over again through the cardiac cycle. Sinoatrial node fires, sends signal to the atria, signal goes to the AV node, pauses, and then signal refires down the bundle of His into the Purkinje fibers, causing the ventricles to contract. And depending on which one of these parts is malfunctioning, this can result in different types of disease states that can occur. You can also have diseases where part of the electrical system is firing by itself. So you may have a portion of this His-Purkinje system that's firing all by itself when it shouldn't be, and this can cause disease as well. Now, interestingly, remember at the start when I said that the sinoatrial node has this like constant reset where it just fires, reset, and then it's going to be have influences from the rest of the body. So if you're stressed and your sympathetic nervous system is up, then it's going to be beating very quickly. If you're sitting, resting, relaxing, then it's going to be beating very slowly. But each part of this electrical system has an intrinsic rate such that it'll always fire at a specific rate. So if the AV node never gets a signal, it'll always fire at 40 beats a minute. If the bundle of His never gets a signal, it'll always fire at a rate of around 20 to 40, usually around 30, and then Purkinje fibers around 20. And it's kind of like a backup safety system, so that if something happens further up the chain, there's something to kind of take over and keep the heart going. The SA node, I know it says 70 beats per minute here. The intrinsic rate is somewhere between 60 and 100, but this can be anywhere between 50 and 180 as a maximum heart rate. So we look at the EKG as a sign of kind of what electrical system is going in the heart, and we correspond the different parts of the waveform that we see to the different parts that are firing. So when the sinoatrial node fires and the atria contract, that's detected by the P wave. And when the AV node bundle branches go and the ventricles contract, then we detect that in the QRS complex. And then when everything is resetting, sorry, not everything, when the ventricles are resetting, we detect that in the T wave. And so when you see an EKG and you see all these squiggly lines, this is all we're seeing. We're seeing the atria contracting, the ventricles contracting, and the ventricles resetting, getting ready for the next cycle. Now you might be asking, well, what about the atria? Don't they reset? They do reset. They're resetting during this period. Let me make sure you can annotate. They are resetting during this period here, where so the atrial P wave, if you want, or sorry, the atrial T wave, if you want to call it that, the atrial repolarization gets buried somewhere in the QRS complex. So you never really see it, but it is there. Also note where I talked about how the SA node fires, signals go to the AV node, atria contract, and there's that pause. The gap between the P wave and the QRS complex, that's that little pause there. And you can see that in this nice diagram here, which I got from this website, ecgwaves.com. If you want to learn more about EKGs, get training, this is a great website. No affiliation, no monetary or anything. I just happened to find it. It was really good. I think that's all I want to talk about that there. Now, okay, one thing to note, even though I'm saying that when the SA node and the AV node all fires, those specific firings of the node are very weak signals. They're too weak to be detected by a regular EKG. So what you're seeing in each of these waveforms is actually all the muscle contracting, or rather the electrical signal of all that muscle contracting. So the SA node fires right at the very start of this. But what you actually see in the waveform is the electrical signal from all that muscle contracting. Now, if you take that EKG and you actually plot it against the volume and the pressures in the various cardiac cycles, you can do that. And you can actually create what's called the cardiac cycle diagram, or a Wiggers diagram, named after Carl Wiggers. And then you can follow the path of blood in all the different chambers and line it up to the electrical activity. Now, I'm not going to go through this fully because it's a complicated diagram and we have whole lectures on this. But if you just Wikipedia Wiggers diagram or Google Wiggers diagram, there's some great explanations out there and it'll show you. But you can go through the entire cardiac cycle and line up all the different things that are occurring. So here we have the P wave, sinoatrial node fires, atria contract in the P wave, and we can see here this orange trace, the atrial pressure is increasing because those atria are contracting. And they're going to reach a point where the mitral valve and tricuspid valve are going to open, and the atria are going to dump all their blood into the ventricles. And we can see here that the pressure inside the ventricle is going to increase as the ventricles fire until the aortic valve and pulmonic valve open. then we get ejection of blood to the rest of the body. And as that ejection dies away, the pressure is going to fall, atrial valve closes, ventricular pressure drops, and atrial get ready to fire again. So have a look at this diagram if you're interested. It's really interesting, just good understanding of cardiac cycle and cardiac physiology, and you kind of base every disease off of this, like everything else. All right, so if we have an electrical system, we can have problems with the electrical system, and any disease of the electrical system can cause an arrhythmia or a problem with the rhythm. And there's different ways that you can classify these rhythm problems. You can classify them as either being too fast, and that's called a tachyarrhythmia, like when you think tachycardia, it's going too fast, your heart rate, or it can be a bradyarrhythmia, as in the heart rate's going too slow. You can also classify the arrhythmias on the location, so you can have arrhythmias derived from the atria, you can have arrhythmias derived from the junction, which is where the AV node sits, or you can have ventricular arrhythmias, which are problems that arise from either the muscle or the distal parts of the His-Purkinje system. And then also depending on how the rhythm is presented, you can either have a block rhythm or a reentry rhythm, or a problem with automaticity, that's the natural pacemaker function, or a problem with prematurity. Now, rhythm problems are very complex. So I wasn't going to get into specific treatments, but if you do want to know if treatments, if you're going too fast, then you give drugs to slow it down. If you're going too slow, then you get a pacemaker. And if you have a rhythm that'll kill you, you get an implantable defibrillator. That's very broad strokes treatment. But if you're interested in arrhythmias and electrical systems some more, we can, I think I have a talk coming up in November, and Nick can send your email to Nick or Dave and they'll contact me and let me know to do that. All right, so any questions on that? I see 2 questions, okay. Oh, thanks Dave for putting that in, and I think okay, perfect. Now, Nick's all over that, thanks Nick. One thing I should probably say is, let's just go back to this diagram here. So one question that people always ask is, well, why do we need these different systems? Why can't the electrical signal just go straight down into the ventricle? Why does it have to go via the system? Well, part of the reason is if this was all connected directly, then you could have a problem where the sinoatrial node fires, goes down into the ventricles, and then the signal could go back up into the atrium. It could set itself up as like a loop, and this can occur. This is called a reentry circuit. However, the heart, being a special organ that it is, actually has various fibrous structures that basically act like insulators, and they sit right over the valve structure and separate all the chambers, not just physically, but electrically, so that the signal from the SA node will never reach the ventricle except via the AV node. And this is both good because it'll prevent the SA node from misfiring the ventricle, but this can also be bad because if something happens to the SA node and the AV node never fires, or the SA node is working, but there's damage to the AV node from a heart attack per se, then the ventricles will never fire faster than what their own intrinsic His-Purkinje system is doing. So, but it's a smart system because it allows conduction to occur, to have synchronous recruitment and contraction so that we have proper blood flow. There's a question from Brian. What is the impact of inverted T waves in coronary disease and the effect on pressure and volume? Good question. So I'll come to that a little bit in my coronary, when I talk about more about the coronary system. So so all these different waves, let me just go back over here. So when we see these waves, this is kind of what a normal waveform looks like, but it really depends on what lead you're looking at. So an EKG, when it's looking at the different heart parts, we attach leads to different parts of the body. So we have limb leads, so we attach them to the arms and the legs, and then we have chest leads, so we attach them in a strip across the front of the chest. And depending on where a specific lead is sitting, it's receiving signal in different way. So the reason that this P wave is upright is because the majority of the electric signal is headed towards that lead. And let's say that, and generally the SA node fires from, actually you can see my camera here. Good. Generally, the SA node fires from, it sits here kind of in the upper right portion of the right atrium. When it fires, the general direction of the signal is kind of from here, kind of going down like this. So coming forward and down because it's heading towards the AV node. And so T waves are going to be the same, is that it's the opposite that's occurring with a T wave. It's repolarization. So depending on where the lead is sitting, it's capturing the amount of that electricity going in that direction. So when we have an inverted T wave, that means that the repolarization, something funky is happening. Normally when we have let's say a lead sitting on the front of the chest, the majority of those should be upright T waves, a T wave that looks like this. But what can happen is like, let's say you have a heart attack there, that muscle isn't going to be functioning normally. It's going to repolarize in an abnormal method, and that might cause a T wave to look inverted or do other funky stuff. Does that answer your question? I hope it does. I'm moving on. I'll circle back to it at the end if we have time. All right. And okay, so now we're going to talk about coronary blood flow. I'm going to spend a little bit more time on this because I think heart attacks are interesting and there's a lot of cool things we can do for them. And I think this kind of bounces off nicely of Dave's talk that came a few weeks ago. So we're going to start off by talking about the anatomy. So not taking no credit from this. This is from a guy named Chris Talbot from, I'm assuming, some med class from 2012, but props to you, Chris, because I used this diagram to study when I was in med school. So I remember when I was talking about the aortic valve, and its secondary function was actually to help direct blood flow into the coronary arteries. So the aortic valve is a tri-leaflet valve. It has these 3 cups. And what happens is when the aortic valve closes, these cups kind of open up to catch the blood. And that's where the right and the left coronary arteries sit. And the coronary arteries are what actually supply blood to the heart muscle and give it the oxygen that it needs in order to contract. And there's 3 cups. There's a right, left, and what's called the non, because there's no coronary artery in that one. And that's what happens is when the aortic valve closes, the blood rushes back this way because of the vascular resistance of the body's vascular beds. And you get blood flow through the right coronary artery and the left coronary artery, which then divides into various parts to supply the different parts of the blood. Now, just like the whole rest of the body has a venous system, the heart itself has a venous system. It's just no one ever talks about it because it's not really important except in a couple of situations, like in cardiac surgery. But all the blood comes back through various different veins and goes to the coronary sinus, which then drains into the right atrium. So all the blood comes back to the right atrium eventually anyway. But just like anywhere else in the body where you have the ventricles pumping out blood, goes to the brain, and then comes back through the superior vena cava to the heart. Just like that, the heart has its own mini circulatory system the same way. Now, the actual structure of the circulatory system is fairly complex, but it's basically feeding all the different main parts of the heart. So we have the right and the left coronary artery. The right coronary artery goes around to the right side and the back of the heart. And at the back of the heart, it forms a branch called the posterior descending artery. And this is what supplies the kind of back and bottom portion of the heart. The left coronary artery has a very short main course, and that's why it's called the LMCA, left main coronary artery. It's a very short portion, and then it splits into what's called the LAD and the left circumflex. Left anterior descending artery is the LAD, and then the left circumflex. The circumflex goes around the back and will either kind of end there, or it will become the posterior descending artery in 1/3 of patients, and through also marginals. And the LAD is the main blood vessel that supplies both the septum, so the middle portion of the heart that separates the left and right ventricle, as well as the main front portion of the heart. This is what we call, this is kind of what people call widowmaker lesion, because if you have a blockage in here, then you're kind of knocking off the majority of your left ventricle, and that's what can cause big heart attacks. Left main is like a double widowmaker because you basically like lose the entire left side of your circulation. And if you have a left dominant circulation, then you lose like everything. So this gives you an idea. But generally, this is kind of what's called like the norm, and then there's some variations from this. So right coronary artery goes and forms a PDA in the majority of people and supplies the right side of the heart, and the left main coronary artery splits into the LAD, left anterior descending, and left circumflex. The left anterior descending is the most important, supplies septal branches, and what are called diags. Now, with this, what's referred to down here, what this diagram shows, what's called dominant circulation. And when you talk about dominant circulation, you're talking about what is supplying the posterior descending artery. So in the majority of people, 2/3 of people, the posterior descending artery comes off the right coronary artery, but in 1/3 of patients, it comes off the left. And then in some patients, like 5–10%, both supply as a co-dominant circulation. Sometimes you can also have the LAD that sneaks around the bottom and feeds it from the bottom as well, but that's a rare variant. Now, when you have these different blood vessels, you can have what's called cardiac territories, and these are different regions of the heart that are supplied. So as I said before, the right coronary supplies kind of the right and the bottom of the heart, not counting abnormal variation. LAD supplies kind of the front and the middle, distal LAD the tip, the left circumflex the left side, and the PDA supplies the back. Now, the electrical supply is also supplied by the same blood flow, and the SA node is kind of 50-50, depending on if it's supplied by the left or the right, 60-40 actually. But the AV node, for the most part, is supplied purely by the right coronary artery. The last thing to kind of note is that the mechanical supply, so remember I talked about those two tiny vessels that are in the ventricles for the tricuspid valve, the mitral valve, that hold the valves in place. They are also supplied by this same coronary blood flow. And the mitral valve specifically has an anterior muscle and posterior muscle. And the anterior muscle has a dual blood supply. It's supplied by both the left anterior descending and the left circumflex. But the posterior muscle is supplied solely by the PDA. And that makes it very susceptible to disease. And so when people describe a leaky valve, one thing to look for is whether you have disease in the right coronary system, because that might cause the muscle dysfunction and cause leakiness. Now, when we actually talk about coronary perfusion and how the blood actually gets to the muscle, the important thing to note is that the perfusion to the left ventricle, and I'm going to talk about the left ventricle because that's the one we really care about, but don't get me wrong, I'm really interested in the right ventricle. I actually like the right ventricle more than the left, but we're going to focus on the left ventricle for now. The coronary perfusion in the LV is intermittent. And the reason for that is that the left ventricle needs to squeeze blood out to get to the rest of the body. And it's generating a very high force. And when it's generating that force, there's no room for blood to get into the tiny capillaries that are feeding the rest of the muscle. So it's actually, in a way, it's starving itself for oxygen when it's pumping. But we've adapted, and the heart actually does just fine when that happens. And what determines the amount of pressure that's going down those coronary vessels is the difference between the aortic root pressure, so that's the pressure right at the aortic valve, as well as the difference between that and the what's called the LVEDP, the left ventricle end diastolic pressure, or the pressure inside the ventricle at the end of diastole when the ventricles are relaxing. So the left ventricle is only going to perfuse during diastole when it's relaxing, because that's when the aortic valve is closed, blood is going down the coronary arteries, and the pressure in the ventricle is low, which allows blood to flow to the left ventricle. The right ventricle is a low pressure system, so it's perfused during systole and diastole. And here's the reason why, is because those blood vessels are all on the surface of the heart, and then they send these perforators down into the muscle. And so you have the LAD, for example, running along the outside, and then it's going to send these perforators down. Those perforators get smaller and smaller and smaller as they go towards the inside of the heart, something called the endocardium, inside endocardium. Myocardium muscle middle portion, and epi is the outside of the heart. But these vessels get really tiny as they get further and further inside. And so you can imagine that when that muscle contracts, all these tiny blood vessels are going to get closed up. There's going to be no blood flow. And that's why the left ventricle is only perfused during diastole when it's relaxing. Now, the heart is a very efficient muscle for extracting oxygen, and primarily the amount of it's extracting almost the maximum amount of oxygen possible because of how much work it has to do. It has to keep pumping over and over and over again. it's become very efficient at this. And when you actually look to see how much energy is being used, or like what it's being used for, the majority of the work that's being done by the heart is being used to pump. It's pressure work. 20% of it is just used to like make sure the cell doesn't explode, basal requirements, and then some of it is used to just help relax. That's what we call volume work. And it's so efficient at extracting oxygen that the blood returning from the heart to the right atrium has a saturation of 30%. And you would think, well, how much is the rest of the body? Well, the rest of the body extracts about 25% of oxygen from the blood, whereas the heart's extracting 65% of the oxygen from the blood, which is, it's incredible. It's extracting all this oxygen. So when you actually look at the blood returning to the right side of the heart, if you were to measure it, and we can do this, we can stick little catheters and measure this. So if I look at the blood returning to my right atrium, say from my jugular, which is supplying blood from the heart, it's going to have a saturation of about 70%. But if I stick it in the coronary sinus and measure that, it's going to have a saturation of 30%. And this is important because that means that unlike other tissues, which can just extract more oxygen if needed, the heart muscle really can't extract any more oxygen. It's already extracting all the oxygen that it can get its hands on. And so what that means is that if the heart has to work harder, it has to get more oxygen by receiving more blood flow. And that's an important concept. And that is why when you have a narrowing in that blood vessel and you can't deliver more oxygen, you can be at risk of having a heart attack. So when we actually look at what determines how much oxygen the myocardium, the heart muscle, receives, we can look at it on a balance of supply and demand. And if you're going to remember one thing from this lecture, I would say remember this slide, because this is like everything you ever wanted to know about heart muscle myoperfusion. You can talk to cardiologists about this and they'll be like, yep, you got it. You know what you're talking about. So let's break this down. So the heart muscle supply, the supply of oxygen is determined by a couple different factors. It's going to be determined by the heart rate. And the reason the heart rate plays such a big role is because remember when I said that that diastole is the only time that the LV is perfused? Well, the slower your heart rate, the more time the heart spends in diastole. Because when the heart speeds up, the time is first taken away from diastole before systole. So as you increase your heart rate, you decrease diastolic filling time. It's kind of counterintuitive when you think about it, because if you're speeding up your heart rate, you actually need to increase the amount of oxygen coming in, but you're decreasing the amount of time you have in filling. But majority of us, young and healthy, big, nice coronary arteries can handle that no problem. So heart rate is the most important factor of supply because of diastolic filling time. It's also going to be determined, the supply is also going to be determined by the coronary perfusion pressure. And remember, that's the difference between the aortic root pressure and the pressure inside the ventricle when it's relaxed. That's going to drive the pressure gradient down from the aorta all the way down through the little coronary arteries. And then the other factor that's important is going to be the arterial oxygen content. And that's primarily going to be driven by how much hemoglobin you have, which in the majority of patients is not going to be an issue, but in patients who might be severely anemic and who might have small coronary vessels, this can be an issue. And then coronary vessel diameter, this is going to be the primary cause of disease. As those vessels get narrowed, then they're going to have more resistance and have more of an impediment to flow. So that's the supply side of things. What's going to determine the demand? Well, basal metabolic requirements, we already talked about that, about 20%, not much. And the heart rate. And in this case, heart rate is both a supply and a demand issue. It's a demand issue because the faster the heart's going, the more oxygen it's going to need to keep up with the work that's going to be going on. So it's heart rate is both a determinant of oxygen supply and oxygen demand. One other factor comes down to kind of our preload, afterload, and contractility, but I'm going to call it filling pressure and contractility, and that's going to be how much the heart is going to be filled and how hard it's going to be pumping. And this kind of has a twofold effect. The contractility makes sense because the harder you're squeezing, the harder you have to pump, the more energy you're going to need for that. The filling and pressure has to do more with how well the heart can pump based on how stretched it is. And I kind of like thinking about it as how much work needs to be done. So if you have a heart that's pumping normally at a normal size, and all of a sudden you increase the amount of volume it's getting, that heart muscle is going to be stretching a lot more than it's used to. And if you think about it kind of like a rubber band or like a balloon. You stretch that out more to contract it back in. You need more energy to bring it back in and push. And so if you fill the heart up more, it's going to need more energy to contract and stretch back in, because it's having to, in a way, cover more distance to contract in the way it is. So the heart likes to be slow and likes to be a little bit less on the full side, if you know what I mean. And so that's why the most important determinants of both the supply and the demand are the heart rate and the ventricular and diastolic pressure. Or you can just mention the pressure inside the ventricle. FYI, that's about the most complex we're going to get, deepest into physiology. This is just what I find really cool. So that's why I want to spend more time on it. Okay, so as I said before, if you get a narrowing in the blood vessel, that's going to cause a supply and demand mismatch, because you're going to have a blockage that's going to prevent some of the blood flow from going down. And whatever area that artery is supplying is going to be not receiving as much blood flow as it needs to be. And this will cause the spectrum of disease from either a little bit of ischemia, so an area that might just be a little bit starved for oxygen, all the way to permanent injury where that whole area isn't receiving as much oxygen as it should, and it dies off. And the primary cause of ischemic heart disease is atherosclerosis, which is plaque formation inside the coronary arteries. And these plaques are usually filled with lipids and fat, and there's some macrophages get involved, and these can grow over time. And then they can either grow over time slowly to a point where they come noticed because people get chest pain, or they can rupture suddenly and cause a sudden blockage and cause a heart attack. Now, atherosclerosis doesn't just happen in the coronary vessels, it happens everywhere else. You can get narrowing in blood vessels that supply the brain, and that can cause a stroke, narrowing in the kidneys, and that can cause kidney failure, narrowing in the blood vessels that supply the gut, and you can get gut ischemia, or in the legs, and you can get peripheral vascular disease. So it's not just, it's the same type of disease process, it's just has certain important implications in the heart, has certain important implications in the brain as well, but we're focusing on the heart because that's the topic of this lecture. And here we have a pathological slide view of a heart vessel. So on the left side, we have a normal, healthy 32-year-old, nice, big open lumen. So the blood would be in here. This would normally be full of blood. And the coronary vessel, being an artery, has 3 layers, which you can kind of see here, 1, 2, and 3. Here we have an 80-year-old. These crystals here are actually cholesterol crystals, these kind of fine spiky looking things here. And then we have medium, and this here is actually some necrosis. So this is where part of the blood vessels actually kind of died off. And then you get this thin kind of cap here that forms. It's trying to section off all of this nasty stuff inside the vessel. And what can happen is that cap can burst and rupture. And this is how much room is left for the blood, this tiny little sliver for the blood to go through. And that can cause a heart attack. Now, when we look at atherosclerosis or development of ischemic disease, we kind of think of all the big players, all the things we think about when we're thinking about the heart attack issue. So male patient, older age, high cholesterol, high blood pressure, cigarette smoking because that increases inflammation, diabetes for the same reason, obesity, sedentary lifestyle, and genetic factors, family history play a part as well. But you can see that as age is probably one of the biggest factors, along with gender. And then I don't have the other factors here, but smoking, diabetes are the next 2 probably higher ones, along with certain high cholesterol and dyslipidemia states. And I saw a question pop up here. Does that necrosis cause a higher likelihood of dissection or embolism? So that necrosis that I'm talking about in the vessel, so this necrosis here, that's inside the vessel, so that's all kind of capped off on the inside of the plaque. So the body will never see that until you have a rupture of this cap. So it's kind of hidden away in there, but it can drive some of the processes that may cause that cap to rupture and occlude the lumen completely. And Buba has a question. How much more at risk of a heart attack are you if you are diabetic? I don't know the overall risk numbers. We do like a scoring system, and you kind of add a point to it that's called the Framingham risk score, and you add a point for everything, and then there's a risk. It's not as high as like some of these numbers. I can look it up and get back to you guys after at some point. Next to like a person without diabetes, I would be totally guessing. I just know it's higher risk. A smart cardiologist can give you the exact number. All right. So I do want to differentiate a couple terms because we're going to be using them a lot in the next couple of slides. So the big two terms that people get confused about is myocardial ischemia and myocardial infarction. So ischemia is when the heart muscle is starved from oxygen. It's hypoxic. It's receiving low oxygen. And this is generally a transient problem in that once you fix it, it should get better and the section will no longer be ischemic. Whereas when you have a myocardial infarction, that muscle is dead. It's infarcted. It's already died off, and basically almost no recovery is possible at that point. Now, that being said, and there's always a caveat to these things, sometimes that section of the heart may look infarcted based on EKG pattern or what you're seeing on a echocardiogram, but it can be referred to as what's called hibernating, which means just sleeping, where it means it looks dead, but if you give it oxygen and you give it time and you give it the right therapy, it may recover well afterwards. But generally, ischemia is a reversible insult and infarction is non-reversible and death. And when we talk about the different diseases that can occur, these are all lumped into a syndrome called ACS, acute coronary syndrome. And this is a spectrum of disease all the way from unstable angina to NSTEMI, sorry, that should be NSTEMI, there's no A there, and STEMI. And these all mean different things. So STEMI stands for non-ST elevation myocardial infarction, and and STEMI stands for ST elevation myocardial infarction. And what they're referring to here is this refers to the presentation that you see on the EKG when these patients present and you do an electrocardiogram. And the ST segment is a segment between the QRS complex and the T wave. And this may be up or this may be down. And generally, when you see an elevated ST segment, that means that the segment is infarcted. And it has to do with how the electricity is being conducted through that dead muscle. Whereas when you see depression, generally it's an ischemic segment. And as we had that question before about T-wave inversion, same kind of thing, that's generally seen in an NSTEMI or an unstable angina. I saw a question pop up here, a couple questions. We always had to talk about time as muscle in terms of field management, STEMI, early transport, etc. Can you talk about treatment efficacy when we have time for management? Nick, it's like you have my slides in the future because that's coming up in a second. So what differentiates all these different spectrum really has to do with how much muscle is being starved of oxygen and how permanent that injury is. So we have people walking around with what we call stable angina. They have small blockages in their, sorry, I shouldn't say blockages. They have small narrowings in their coronary arteries. But those narrowings are small. And if they push themselves quite a bit, they may get some chest pain because they're starting to feel some ischemia. But if they rest, they allow the heart to recuperate. They may just take a swig of their nitro. It gets better and they're totally fine. And these patients are managed, there's lots of patients that are managed like that with stable angina. And the blockages don't get any bigger. It's just something they live with. But what can happen is that you can progress. And those blockages might get bigger. And now you might start getting into unstable angina, which is characterized by escalating amounts, or you're starting to have chest pain even with very minimal activity or even at rest. And now what's happening is that now you're becoming more ischemic at lower exercise amounts. And now your EKG is starting to become affected as well because of the amount of ischemia going on. But the important thing to note is that there's no death of muscle. There's no necrosis or area of infarct because when we measured the blood and look for these things called troponins, which is a molecule or a protein that's released from dying heart muscle, we don't see any. So both stable angina and unstable angina, there's no troponins. So when they go and measure blood work, there's no sign that any muscle is dead. But in unstable angina, we're starting to see EKG changes that indicate that the muscle might be compromised in terms of its oxygenation. Now, that can progress to a full-blown myocardial infarction, where we've now have dead muscle tissue. And it can either be an NSTEMI, non-ST elevation MI, or a STEMI, ST elevation MI. And the main differentiator, apart from the pattern on the EKG, has to do with the size of the infarct, so the size of the dead tissue, and how much of the wall is affected. So generally in an NSTEMI, it's just the very inside of the heart muscle, that endocardium, the part that's closest to the inside, where those tiny little vessel perforators are going that are very starved of oxygen, that can die. Whereas in a STEMI, we have a full, complete wall segment, as you can see here, that is dead or dying. And that's a very acute emergency. Don't get me wrong, these are both acute emergencies, but that's a very bad one that's there. And as I said before, in both of these, troponins, which are those molecules that are released by dead or dying muscle tissue, are going to be elevated, and we can measure that in the blood. Okay, I've seen a lot of questions pop up. Let's go through here. Okay, so time is muscle. Nick acknowledges that. And ALS paramedics. So we're going to talk about thrombolysis, about that. And does unstable angina require a rupture of a plaque or simply result in large plaque growth? No. So you can either have a plaque that ruptures but doesn't fully occlude the blood vessel, and that might be enough to switch stable angina to unstable angina, or you may just have progressive narrowing over time that narrows very rapidly for some reason, either because of localized inflammation, change in medication, increase in patients' exercise tolerance or activity level that they didn't know about. And these can be very sinister. When you think about like the patient that kind of presents that like bam, like all of a sudden out of nowhere chest pain, that's usually going to be like a plaque rupture, STEMI or NSTEMI kind of event. When you think of a patient who's like, man, like I've been at home, I'm feeling more tired the last couple of weeks, I'm getting some chest pain more and more, like as I'm going down, up and down stairs, that's more kind of in the unstable angina, stable angina spectrum. It's all a spectrum of disease, and really it's until you have the EKG signal and the troponins and a smart cardiologist or emerge doc to kind of figure out which way these patients are going, that you can determine how you're going to treat the patient, which is what we're going to come to next. So as Nick alluded to earlier, time is muscle because there's only a certain amount of time that we have to get reperfusion of those areas. And the amount of time that we have to get the patient to a cardiac center is going to determine the type of therapy that they have. Now, generally, you're kind of wanting to get somewhere in the range of 30 to 60 minutes. Less than 90 minutes is ideal in order to get an intervention done by a cardiologist in an interventional cath lab. And that has to do with how much you can limit the amount of size of infarct. And the idea kind of is that by 90 minutes, and this is totally variable as well, but these are what our guidelines are based on, but before 90 minutes, you can limit the amount of infarct to endocardium. So you can potentially save all of this heart muscle in the beige here, because the dead part is all endocardial, and you'll still be able to recruit a good amount of save a good amount of the outside muscle. Whereas when you're going past that, past the 2-hour mark, then you've kind of established your heart attack. You've killed off that entire full wall of muscle, and you still need therapy. You still need to potentially need the reperfusion of that, because there might be other territories that are fed by that area that you want to make sure you open up. But generally, that's kind of our range, and that's kind of where we talk about what therapies we're going for, which I think is my next slide. Nope, it's not. We'll come back to that. Now, when somebody has a heart attack, a myocardial infarction, there can actually be different types of it. And this is kind of alluding to what I was talking about before, is that you can it all comes down to supply-demand mismatch. But what it really matters is kind of how quickly that supply and demand mismatch occurs. So a type 1 myocardial infarction is the one we kind of classically think about. Someone's kind of walking along and then, bam, out of nowhere, they have that chest pain because all of a sudden they've had that spontaneous plaque rupture or erosion. And they've gone from maybe like a 50 or a 60% stenosis to like 100% occlusion. And that's kind of like the big jammers that they talk about that get rushed to the cath lab quickly. But you can also have something called a type 2 MI, where you have a narrowing in the blood vessel, but under normal circumstances, wouldn't cause much of an issue. But all of a sudden, let's say that you increase the demand on the heart. All of a sudden, that heart needs to pump faster than it's used to, but it already has this blockage. And now that area is going to be starved of oxygen. And maybe patients don't notice it. Maybe they have no control over what's going on. And for whatever reason, that area is going to be starved for a long time. And it's starved for so long of oxygen that it begins to infarct. So kind of like classic story is when you think about it, it's like the guy shoveling snow who's, elderly gentleman shoveling snow, doesn't really take care of himself, not that active, but man, December hit, he's got to clear his his driveway and sidewalk. So out he goes into the snow. It's a little bit chilly. Maybe he's he doesn't really feel stuff as well because he's like an old timer and just wants to get the job done. So doesn't really notice that he's having chest pain at the time and he's actively infarcting at the same time. Or one that we see in the operating room that can happen is somebody who has a blockage here like this, but then a stress gets put on the body, like say surgical stress. So either they're not tolerating the anesthesia or they're very sick and they're septic and their heart rate's up, and all of a sudden that myocardial demand is a lot more than what the patient's normally used to, and they can actually infarct the territory. Now, there are other types of MI, and these are mostly semantics because you'll never be seeing these. Well, I guess you might see type 3, but type 5 is a heart attack that occurs when you're having surgery to bypass your vessels. Type 4, either A or B, is when you're having a stenting procedure done, you have a heart attack. And type 3 is what's called a presumptive heart attack, where you die from your heart attack, but they aren't actually able to confirm it because they weren't able to draw blood work. But for the most part, we're talking about type 1 or type 2. Now, Dave had an excellent talk in his thing about kind of the pre-hospital management of ischemic chest pain and heart attacks and what we can do there. So I'm just going to talk about kind of a bit more of the advanced therapies. I'm not going to go into specifics about like what time do you do what and what not. But I'll just kind of give a brief overview. So, and this is both for, these kind of apply to both urgent acute coronary syndromes or for just stable management of ischemic heart disease. So one thing you can do is medical management. Try to optimize supply demand, slow the heart rate down to improve the amount of time in diastole for your myocardial oxygenation. Give other drugs to kind of decrease the amount of work that the heart's doing. That's kind of the mainstay of medical management. I'll go into some of those drugs in a little bit. Somebody's having an active heart attack in front of you, you can also give thrombolytics, which are very strong clot busters, and you give them through the IV and they go systemic, so they can go everywhere, and they'll break up any clots that are in the body, and they want to focus on any clots that are in the heart so that you can reperfuse and get blood to where it has to go. But the kind of gold standard for treatment is angioplasty, and that's where you take a little wire and you feed it up the artery, either through the wrist or through the aorta, and it goes into one of the coronary arteries, and you feed that wire through the clot, and it has a little balloon on it, and then you puff that balloon up and break the clot up. And most of the time, you're going to leave a stent behind. A stent is a little wire cage, and that stent will prevent that area from narrowing ever again. POBA is a kind of funny term. It stands for plain old balloon angioplasty. That's where you go in with a wire and puff that balloon up and just break up that clot. And then stenting, you can either leave a bare metal stent, so just a metal cage, or you can leave a drug-eluting stent, which is a metal cage that's coated in specific drugs that prevent a clot from forming in that location again. And if you have lots of different blockages, you can either have them all stented, or you can go for heart bypass grafting, especially if, say, the interventional cardiologist is not able to get to where they have to in terms to try to break up the clot. Coronary bypass grafting is more for kind of stable ischemic disease. You wouldn't, well, I shouldn't say wouldn't, because we did, but, or we do, I should say, but this is more for like after someone's had a major event and you find that they have other places that need to be bypassed. Generally, though, is angioplasty is kind of your emergency treatment, but there's also patients who will go and have angioplasty and stenting because, say, for stable angina that's getting a little bit worse, or they go and they want to treat a lesion before it can become worse. Right. So here's that picture of angioplasty, as I said. So they'll either insert a little catheter, a little plastic tube in the radial artery in the wrist or up the femoral artery in the leg, and then fire a wire up the aorta into the heart and into one of the two coronary arteries. And then over that wire, here we go, over that wire, they're gonna bust through the clot, inflate the balloon to break up the clot, and then you have clear blood flow. And then down here at the bottom, you can see that that balloon has a little stent on it, a little wire cage. Inflate the balloon and then leave the stent in place. Here's what it actually looks like when it's being done. So on the left, this is the right coronary artery. And you can see that there's a blockage here where the arrow is, arrow sign, very helpful. And then they've gone through and they've opened up that blockage, and now we have good flow distally. Now, the flow here is actually not bad. Like, you can actually see that between the two images, like the flow distal is basically the same. So this is probably a lesion that was causing problems not at rest, not at rest necessarily, but maybe this patient was having some angina-like symptoms with more activity because this lesion was a critical stenosis. Compare that to this heart, which has, this is the LAD here, and it shouldn't be long and spindly like this. It should be nice and big and thick. And so what they've gone is they've gone and they've stented a whole bunch of different places. And now you can see a nice big thick LAD down all the way to the bottom. So that's what angioplasty looks like. And then you can also go for coronary bypass grafting. So this is where, this is basically open heart surgery, where the surgeon goes in and takes grafts from various places. So usually a graft from the veins in the leg, or they'll take an arterial graft, either an in situ graft. So that means they're going to take one of the arteries that feeds the front of the rib cage and dissect that off and plunk it onto the LAD, or they'll take a graft from like an artery graft like the radius. So they take a length of your radial artery here, and they'll graft that and the aorta. And then you bypass basically all the blockages that way. But that involves some form of hard lung bypass, which is definitely above anything St. John should talk about, but involves having to hook up to a hard lung machine with various cannulae and whatnot, so they insert a cannula into the right atrium. So instead of the blood going back to the heart, it now goes into the hard lung machine where it gets pumped through an oxygenator and a filter, and then returns to the body via the aorta, which basically takes the heart out of the equation. And then they stop the heart and they can graft their vessels and do whatever else they want to do. I saw a question pop up, two questions. Are 4 and 5 related only during surgical procedures? Yeah, so the type 4 and the type 5 MI are really only related to when you're having the procedures done. And yeah, so really it's a hospital thing. You'll in the community, you're going to see type 1 and type 2 MI. It's not that it really changes management for what we're doing. It's more just a kind of cool classification. And then Nick asks, he's wondering about arterial grafts. Aren't those vessels important? How much redundant artery do humans have? Probably quite a bit, because we take arterial grafts quite a bit for various diseases. This one here, the Lima left internal thoracic artery graft. So it's one that sits on the inside of the rib cage here and kind of feeds part of the front of the sternum and the ribs. But there's a lot of collateralization that comes from the back and from other arteries. So as long as you have collateral blood flow, you can kind of take what you need to get the job done. And the nice thing about a Lima graft, the left internal thoracic artery graft, is that you don't have to do two joins. So like when you do a vein graft or even a free radial graft, so if you take the radial artery and you take it out and then plunk it into the heart, you have to do two sites of sewing. You have to do one to the aorta and one to the vessel down here. Whereas when you take this one, you just have to plunk the distal end down. And this is better for perfusion. It might mean that you have less complications down the road. Some people even do what's called a dual thoracic artery grafts. So they'll take a lima and the rema. So they'll take one from both sides and plunk that down onto the heart. They'll do that for generally younger patients. And then, yeah, the hand has a dual blood supply. You have the radial artery and you have the ulnar artery. Most people, you can feel both. Yes, I have both. So yeah, so the hand will continue to be supplied by the ulnar artery, so you can take the radial artery no problem. Or I shouldn't say no problem, but generally without problems. No, I'm not going to talk about reperfusion ischemia. That's going to be something, that's going to be for part 2 of the talk if we ever go on to it. All right. So generally after patients have a heart attack or patients are discovered to have coronary disease, they get put on kind of what we call the anti-ischemia regimen. So these are medications that we're going to use to try and optimize our supply-demand mismatch that's occurring. So we've had a clot that's formed in that coronary artery, so we want to prevent that clot from occurring. And generally, all patients get aspirin, but generally most patients will be put on a second, I shouldn't say most, almost all patients will be put on a second antiplatelet agent. Most common is clopidogrel, Plavix, but a lot more patients being put on ticagrelor, and we can, I'll get into why in another talk. But most patients, after they have a stent placed, will be placed on what we call dual antiplatelets, so 2 antiplatelet agents for up to a year afterwards, the drug-eluting stent, or 6 months after bare metal, 30 days if you just have angioplasty. After a bypass grafting, usually on it for about 6 months to a year. They also get placed on a beta blocker, medication like metoprolol or atenolol or bisoprolol. And these are medications that are used to slow the heart down, because remember what we said before was we want the heart to be slow to allow that diastolic filling time. It also has other important factors. It prevents a lot of bad remodeling of the heart, so it enforces the heart to have what we call good remodeling, to change the structure of the coronary vessels and other parts of the heart so that it's a better function overall and improve cardiac blood flow. Most of the patients will be placed on an ACE inhibitor or an ARB. These are both antihypertensive, so they're blood pressure medications. Their primary role is to lower blood pressure so the heart doesn't have to work as hard to pump against in terms of the rest of the body. And then all patients will get put on a statin or a lipid lowering medication. These have 2 rules. One, remember we said the plaque is predominantly formed by cholesterol and other lipid deposits. So this will help lower cholesterol, which will help prevent more plaque formation. But we've also found out that statins actually have an anti-inflammatory role and will help prevent that lipid cap from rupturing by decreasing the amount of inflammation in the area. Okay, last thing I want to talk about is heart failure. I also know that it's 80 minutes into my talk, so I can save this for another day. Or if Dave, you think I should just finish it up, it'll probably take me 15 minutes.
I think we haven't had anybody leave for the last hour, so I'd say go for it.
Okay.
For anyone that's on the fence, this is recorded, so if you do have to go or it's getting past your bedtime like it is for me, you will be able to finish this on YouTube, no problem, in a couple days.
It's past my bedtime, can I? No, I'm kidding. Okay, okay, let's talk about heart failure. This is gonna be broad strokes overview. So I guess I shouldn't say if you remember one thing from this lecture, remember that thing from before. If you're gonna remember 2 things from the lecture, the second thing you should remember is the definition of heart failure. So heart failure is the inability of the heart to pump blood to meet the demands of the body, or it can only do so at high pressure. And this definition is important because it defines the different types of heart failure that it can occur. So let's go over that one more time. So inability of the heart to pump blood to meet the demands of the body, i.e. if you have increased activity from either exercise or stress or something, the heart cannot meet that demand. Or it can only do so at high pressure, i.e. it can only do so at higher pressure than it's used to, and this can precipitate it to fail later on, or will cause a backflow of blood to places where we don't want, like the lungs, the liver, and the ankles, where we most see it in most people. The most common causes of heart failure are cardiomyopathy. Myopathy is a muscle-related disease, and cardio means heart. So heart muscle disease. And then you can break up heart failure into the different components. You can either have high output or low output. So heart's being very fast or pumping very fast or pumping very low. You can have left-sided failure where just the left side is affected, right-sided failure where just the right side is affected. And you can have acute heart failure, so it comes on very suddenly, or chronic heart failure, it comes over time. You can see that there's all these different causes of heart failure that can occur. These can be broken up into different things. So most common cause, or I shouldn't say most common cause, but one of the common cause is coronary artery disease, what we were just talking about. So if you had a previous heart attack and you have an area of the heart that's damaged or dead and isn't beating as well as it should, you now have ischemic cardiomyopathy, and that heart is going to not beat as well. The good news is that with proper treatment, you can help remodel the heart and help it recover so that it doesn't have as much of badness going on as it could be. Now, I love this comic because it talks about kind of the 3 different structures or types of cardiomyopathy that can occur as one of the things that can occur. So let's ignore hypertrophic for a second. Just pretend. Let's ignore hypertrophic. Just ignore it. Pretend it's not there. He's really cute, I know, but we're just gonna skip him for a second. So dilated means the heart's too big. For whatever reason, the disease state, we've increased the size of the heart and it isn't able to pump as well because it's stretched to beyond its limit. It's like you blow up a balloon or you stretch a rubber band and you've gone like kind of past that breaking point where that muscle, the band stretches and doesn't collapse back in on itself. Or if you take a slinky and you're having fun with that and then you stretch it even further than it should be and now it doesn't kind of come back on itself. That's kind of the idea with dilated cardiomyopathy. And ischemic cardiomyopathy, so after you have a heart attack, this is one of the ones that can happen because that area of the heart that gets damaged and dies can thin out and stretch out and doesn't beat as well. And the rest of the heart has to kind of compensate for it and work harder. So everything gets big, causing more work on the heart, and the heart doesn't like that. So it either has to pump at higher pressures than it should, or it just fails to meet the demands anyway. Restrictive cardiomyopathy is when the ventricle walls, so the big muscular walls, they aren't able to contract as well, or they aren't able to fill as well. And that can be because of, for example, things that are infiltrating the myocardium. So abnormal proteins like amyloidosis or sarcoidosis, or deposits like hemosiderin, like in hemochromatosis. So less common, but still can be very bad because now these ventricle walls are rigid. They're gonna be under high pressure because they need a lot more pressure to fill them than they can, or they can't contract as well as they could be. And then hypertrophic, we might as well talk about that since it's on the, there we go, since it's on the diagram here. So hypertrophic is when a specific part of the heart, or one part or one side or one segment of the heart gets thicker than it should be. And as a result of that thickness, it causes abnormalities in how the heart pumps. And this can lead to problems down the road. And we had a question here. Keep going. Oh, okay. Yeah, we're going to keep going. So, okay. So remembering those 2 statements, that heart failure is when the heart is not able to pump to meet the demands of the body, or can only pump at higher pressures, we can now form the different types of heart failure. So if we, in a normal state, we're going to have good perfusion. We're able to pump and meet the demands of the body. But if we are unable to meet the demands of the body, then our periphery is going to be, we're going to have poor perfusion. Periphery is going to be cold, brain's going to be cold, or brain's not going to be perfused as well, kidneys aren't going to be perfused as well, gut's not going to be perfused as well. And so this is a form of low output heart failure because we're not able to meet the demands of the body. We're not able to get oxygen to the rest of the body where we want. Come over to the other side of things. So the inability of the heart, or the heart can pump, but it's only pumping at higher pressure. And that high pressure is going to cause a backup, and we're going to start backing up fluid into areas where it shouldn't be. So if it backs up from the left side of the heart, it's going to back up into the lungs, and we're going to get pulmonary edema or wet lung. And if it backs up from the right side, then we're going to start getting congestion in places like we shouldn't, such as extra fluid on the ankles, liver becoming congested. And note that if you have a lot of backup, you can have backup from the left side through the lungs, making the lungs wet, all the way to the right side, causing swollen ankles, high JVP, congested liver, that kind of thing. So remembering those two sides of the table, we can now talk about the different forms of heart failure in terms of how they present. So you can have someone who has heart failure, but they're compensated because in the majority of the time, they're able to meet the demands of the body. They're kept good perfusion, and they aren't at high pressure, so they don't have any congestion. But let's say that we have someone with high perfusion, but for whatever reason, we're having backup of blood. Maybe one of the valves is a little bit leaky, or maybe the heart's having to work harder because of how certain remodeling or certain deposits in the blood vessel. Well, then we're going to start backing up and we're going to start to get wet. Our lungs are going to become congested, our ankles are going to get swollen. And so now we're going to get pulmonary edema or ankle swelling or however you want, but we're going to be warm and wet. We're still able to meet the demands of the body, but we're going to have excess water on board. And so you would treat this by getting rid of that excess water. And so that's where diuretics come in, as well as blood pressure medications to promote forward flow. Let's take it over to this column or this segment here. Here you have no congestion, so you're not at high pressure, but you can't meet the demands of the body. You have poor perfusion for the rest of the body. So this is a low output state. You're cold, but you're dry. And so in this one, what you want to do is you want to give the heart a medication that'll make it beat stronger, like an inotrope, so like digoxin, or we can bring them into hospital and give them special medications that'll make the heart beat faster, create some remodeling, and let the heart recover. So that's a cold and dry state. That's a low output state. Now, the place you don't want to be is you don't want to be cold and wet, because not only are you not meeting the demands of the body, but you're also having backup because your ventricle is failing and you're having backup into your lungs and everything else. So you're cold and wet. And this is bad cardiogenic shock and cardiac failure. These patients are very difficult to treat and usually require multiple medications and interventions to make them better. This is high level stuff. So if you can understand this will be really good after. There's a good lecture on life in the fast lane about this as well, if you have more interest. So when we look at treatments, we can target all these different things to make the heart better. And this is what's called kind of the donkey analogy of heart failure. And it's how we, it's a good analogy for how we treat it. In reality, I don't think of a donkey when I'm treating heart failure. I think of the patient, but this is a good way of explaining. So upper left, we have our poor donkey. He's carrying a big load. He's working hard. He's tired. He's sweating. He's retaining fluid. So what are we going to do? Well, we can lighten the load. We can take some of the work that the heart is doing off by, in the donkey analogy, remove the extra pallets. But what we're doing in this case is we're reducing the amount of blood that the heart has to pump per cycle. So we're going to give them a diuretic, a pill to make them pee extra, and we're going to try and get a lot of that extra fluid off the heart so it doesn't have to pump as much. And in doing so, we're also going to give anti-blood pressure medications. So ACE inhibitors, ARBs, hydralazine nitrates, these things are all going to decrease the blood pressure, but that's going to promote forward flow so the heart's not having to work as hard against what it's pumping. We can also slow the heart down. So hey, if the donkey's trying to push this big load at a high speed limit, we're going to say, nope, you can slow it down. You can take your time. You can work at this pace that's comfortable for you and kind of trundle along at your own rate. And the last thing we can do is we can give it some incentive. We can make it work harder just to kind of overcome the badness that's going. So here the analogies are putting a carrot in front of the donkey, but what we can do is we can give certain medications that will actually improve how the heart is pumping. This is probably the worst part of the analogy because this is basically saying like, okay, I'm going to speed up the heart, but that's not really what we're doing. What we're really doing is it's like we're injecting steroids into the, or like a bodybuilder injecting steroids into the donkey. Like we're making it stronger in how it's pumping. But That's what digoxin can do. But these other medications, dobutamine and milrinone, they have other functions that they do as well, specifically around the pulmonary architecture and remodeling of the heart. So it's not the best analogy for that one, but it gets the point across. And so from that, we can create kind of our heart failure regimen. There's medications that you might see the patients on who might be in heart failure. So beta blockers, again, kind of the mainstay, for making the heart pump slower. So metoprolol, atenolol, bisoprolol, carvedilol. Majority of these patients will probably be on bisoprolol or carvedilol just because they have other benefits to them as beta blockers. As I said before, we're going to give them an ACE inhibitor or an ARB. These are blood pressure medications to control their blood pressure. Diuretics, they pee out any extra fluid that they're retaining, so the heart's not being worked as much. And then there's a special type of diuretic called a potassium-sparing diuretic. It's caused that because it doesn't cause you to pee out potassium. That's not the reason why it's used in heart failure. This medication, spironolactone, actually has a specific, what's the best way to describe it? It acts on a specific neurohormonal segment that causes the heart to remodel in a more adventitious way for pumping. That's the easiest way I can say it. And then inotropes like digoxin, which makes the heart pump better. Now, as you saw from this table over here, there's lots of different causes of heart failure. And that's kind of the general treatment, but a lot of these you kind of treat specifically. So mitral regurg, you can give it all the beta blocker you want, but sometimes until you go in and actually fix the valve, it's not going to do anything. And in fact, mitral regurg doesn't really do well on beta blockers. Mitral regurg likes to be a little bit faster. We can go into that a little bit on another talk, but you might give them a beta blocker for another reason because of other sequelae of mitral regurg that they may have. Ethanol-induced dilated cardiomyopathy responds really well to stop drinking alcohol, as well as all the other stuff that's going on. So you treat the disease based on the specific indications, not just the general kind of shoot all. But for the majority of patients who have dilated cardiomyopathy, ischemic cardiomyopathy, this is kind of the regimen that they're going to be on. All right, that's the talk, guys. Any final questions there? I don't think so. I don't see anything else here I missed. Perfect.
Well, we'll give people just a couple minutes to catch up here. Just a couple things we're going to bring up for everybody. First off, thank you so much, Nav. That was, I think, one of the best talks we've done of this whole series so far. That was really fantastic. Just so for anybody that did trickle in late, these are part of our weekly sessions. We're doing these every single Monday as part of the Division 176 online training throughout the pandemic here. These sessions are all recorded and put on YouTube within a few days of there. You can check us out at St. John Ambulance Division 176 on YouTube. You can also follow the rest of our social media platforms. They're all at SJA Div 176 across all of there. As we're getting into the fall and getting into some of these more complex topics, we're also trying to look at some alternative ways to present them. So if anyone would be interested in seeing these in something like a podcast form, we'd love you guys reaching out to let us know if there's going to be the appetite for us to be putting that kind of work in there.
All right. Lots of things coming in. Thanks, everyone. Appreciate that. It's always fun to talk about these. As I said, it's a big overview topic. So went a little deep into some things, grazed over a couple others. So if there's specific interest in things, I'm happy to circle back at a later date. But yeah, feel free to take some of this and expand your knowledge and read some more about whatever interests you. Okay, have a good night, guys.
Thanks, everybody.